Hello, welcome to our video on hyponatremia. Let's get right into this daunting task. All right, so we're going to follow the basic framework of the clinical problem solvers. Surprise, surprise. However, I just want to quickly add in our steps. So in case somebody needs a really rapid review of how to work through hyponatremia, I'm just going to write the steps here very quickly. So the first thing you want to do is check your serum osmolality, serum osmos. Second thing you want to do is check your urine osmos. For this one, you can use the specific gravity. We'll do last two digits times 30. For example, if your specific gravity is 1.01, you multiply the 10 by 30 and you get 300. Okay. Finally, you're going to check the urine sodium. All right, so very simple. Check labs, you see hyponatremia. First thing you're going to do, serum osmolarity. Second thing you're going to do, urine osmolarity. And thirdly, get the urine sodium. All right. All right, so let's get into this. So the obvious points are number one, if a patient is severely hyponatremic, like having seizures or severely altered, of course you want to treat and diagnose later. Another thing is that a lot of patients will have some degree of hyponatremia, but the vast majority do not need to be worked up. And then finally, third point is that volume status sucks at determining the cause of hyponatremia. Sucks is not the best way to put it. It can be deceiving, and I think it's not a good clinical. It's not clinically reliable. That's what I'm trying to say, and I think it can be used to guide diagnostics, but it should never be used to categorize or exclude diagnoses. Okay, perfect. So we have a patient who is in the hospital. They are severely hyponatremic. First thing we do is check the serum osmolarity. And why do we do that? So number one, if the patient has an increase in serum osmolarity, in a decreased sodium, the reason why they have a decrease in sodium is because those osmotically tonic molecules such as glucose, mannitol, or contrast cause water to rush out of the cells into the intravascular space, thereby diluting the sodium intravascularly. Okay. Renal failure and alcohol, these actually cross the cellular membrane. And so they will be present and they will still dilute the serum sodium, but they also do cross the cellular membrane. So, what I was taught is if you suspect renal failure or alcohol as the cause of your hyponatremia, and you find these osmotically active agents in the blood, then you want to do a further workup to really elicit what the cause of the hyponatremia is. All right, so moving on to this category here. Where did my pen go? Oh, there we go. So moving on to this category here. So I'll explain this pretty simply now. So if we have, we'll draw over here. So let's just say that normally, if this is a column of our blood, normally we would have about this much solid molecules, and then we would use the rest of the liquid to calculate the concentration of sodium. However, in conditions like hypertriglyceridemia, lipoproteinemia, whatever the solid molecule, whether it be fat or protein, is taking up space in the blood, the reason it's called pseudo hyponatremia is because now imagine that this much of the blood is taken up by a solid component, and then the rest of this volume is used to calculate the sodium. Oh, excuse me. So the computer takes into account the entirety of the space, but it fails to take into account the actual decrease in volume corresponding to the decrease in hyponatremia, if that makes sense. So basically, the lab is still utilizing all of this space, but fails to realize that there's a significant portion of solid being taken up here. And so the actual concentration in terms of millimoles is not reduced. It's not able to see the size difference, if you will. Okay. All right. So now moving on. So again, hyponatremic patient. We check the serum osmolarity. We see that it is in fact reduced as we would expect. Next thing we do, step 2, is calculate the urine osmolality now. A quick and dirty trick to doing this, as I mentioned earlier, is you take the last 2 digits of the specific gravity and multiply by 30. The example they give us here is 10, and they get the urine osmolarity at 300 there. So the only condition that can cause um, hypoosmotic hyponatremia is going to be from the diet. And this should make sense, okay? So if your kidneys are working properly and you have dilute serum, then you should also have dilute urine, correct? Yes. In most of the other pathologic conditions, and I'm talking about this branch point down, um, the other pathologic conditions have something wrong with either the kidneys or the other parts of the body where the kidneys are not responding appropriately necessarily for various reasons. Okay, maybe intrinsic to the kidney, maybe extrinsic. All right. So this category in and of itself really is just diet. So if you see hyponatremia in the presence of hypoosmolar urine, then you're likely dealing with some sort of dietary cause of this, and that could be from alcoholics not eating salt, tea and toast, fasting, primary polydipsia, whatever. It doesn't matter. It's diet related. Also, another great clinical pearl that I have picked up about hyponatremia is that you cannot, in fact, get hyponatremic unless the patient is drinking water. I'll say that again. There's no way you can get hyponatremic unless there is intake of free water. Okay, so again, this goes along with our explanation for diet. Now we checked the serum osmolarity, then we checked the urine osmolarity. We see that the urine osmolarity is in fact high. This is abnormal. Next thing we do is go to step 3. We check the urine sodium. Okay, now I'm going to move from left to right. So we check the urine sodium and we see that the urine sodium is in fact low. What does that tell us? That tells us that we have low effective arterial volume. And this makes sense because the RAS system is chronically active, right? So if we are hyponatremic and we have our body is perceiving low effective circulating volume, we're going to have RAS constantly on. And what does RAS do? RAS reabsorbs sodium. So RAS activated means sodium reabsorbed, which means low sodium in the urine. Makes perfect sense. Now, here's where maybe a good physical exam can help to differentiate the causes of low urine sodium. These would be either hypovolemia like hemorrhaging or something versus heart failure, cirrhosis, or nephrosis. Okay. So here's where the physical exam can actually be helpful, and history and all that stuff, of course. All right, so let's go to if we check the urine sodium and we see that it is in fact high. Now there's 5 causes for hyponatremia in the setting of increased urine sodium, and these include number 1, adrenal sufficiency, number 2, hypothyroidism, number 3 is diuretics such as hydrochlorothiazide, number 4 is SIADH, which is a diagnosis of exclusion, and number 5, cerebral salt wasting, which I think of a lot like SIADH. All right. And to differentiate these, of course, what we want to do is check our hormone levels. So we get a TSH, we get maybe an AM cortisol, do a thorough history, see if the patient's been taking diuretics, and so on and so forth. So, kind of to understand a little bit more beyond this algorithm, I want to talk about the molecule of ADH itself. Okay. And I want to mention specifically, I like to write ADH as ADOH because I like to remember that this is a diluting molecule. It causes hyponatremia, ADOH, hyponatremia. Just a quick and dirty way for me to remember that anytime ADH is active, you're going to get hyponatremia. I mean, that's not necessarily true, but for fast and dirty thought processes, thinking about these conditions when you have inappropriate as ADH release or whatever, it definitely helps to understand that ADH goes along with hyponatremia. Very quick and dirty. Okay. So I'm going to talk about some of the things that either inhibit the secretion of ADH or the presence of them blocks the secretion. Either way, okay. So first of all, we have, we'll say ADH inhibitors. Number 1 is going to be cortisol. Cortisol in and of itself directly inhibits the release of ADH. The way that I think about this is that, yes, they're both technically fight or flight hormones, but the way I think about it is if your body can sense that cortisol's around, it's saying, all right, we got cortisol that's active. We don't need you, big dog ADH. We got it. We're enough here, okay? So if you take cortisol away, such as the case of adrenal insufficiency, you're going to have secretion of ADH because the body says, hey, what the heck, big dog cortisol, where are you? Now I got to exhibit my effects to try to increase the blood volume? I don't think so, man. Remember, the body is always set up to protect against hemorrhaging, right? So that's one example. Number 2 is thyroid. Of course, same idea, right? So thyroid hormone is a metabolically active hormone, stimulates the adrenal glands, and yada, yada, yada. Also inhibits ADH. So again, same way I like to think about it is thyroid hormones around. We don't need you, ADH, big dog. We got this. All right. So drops in both of these cause release of antidiuretic hormone. Okay. All right. Another one we should all know is alcohol. Okay. So alcohol inhibits the release of ADH. What else here? Calcium can inhibit the release of ADH. So the abundance of calcium, rather, can inhibit the release of ADH and cause things like diabetes insipidus-like syndromes. All right. Another one is prostaglandins. So might not be as intuitive, but if a drop in prostaglandins or taking NSAIDs can induce the release of ADH. That's why NSAIDs can be a treatment for diabetes insipidus. And then there's also genetic causes, and then, of course, drugs. So drugs such as lithium, amphotericin B, Vaptans, tetracyclines, whatever. And again, they may not be ADH inhibitors, but their presence prevents the release of ADH, and perhaps their abundance may inhibit it. All right. And what else did I want to say about hyponatremia? Oh, finally, I wanted to say that the reason why you become hyponatremic in kidney failure is that you have to know that when you're in kidney failure, the um, the kidneys lose the ability to secrete free water. Okay, so you cannot secrete dilute urine. Basically, you lose that ability, and so that's just another clinical pearl to keep in mind. All right, thanks.